This video will cover the background, etiology, pathophysiology, epidemiology, clinical features, investigations, management, complications, and the prognosis of cervical cancer. The prognosis for cervical cancer depends on the stage at diagnosis. 96% of cases diagnosed at the earliest stage will survive for a year or more. Those who are younger at diagnosis have an improved survival. About 90% of women aged 15 to 39 survive 5 years, whilst just 25% of those over the age of 80 will. Cervical cancer is also one of the top 5 commonly diagnosed cancers in females aged 25 to 49 years, also being the commonest UK cancer in women under the age of 35 years. The biggest risk factor for cervical carcinoma is human papillomavirus. It is thought to be linked to 99.7% of cancer cases. The most common carcinogenic subtypes of HPV found in more than 70% of cases are subtypes 16 and 18. Other high-risk subtypes include 31 and 33. There are also non-carcinogenic subtypes of HPV, known as 6 and 11, and these instead cause genital warts. Other risk factors for cervical cancer include smoking, HIV, immunosuppression, combined oral contraceptive, early first intercourse, high parity, and family history. HPV is a common sexually transmitted virus. Most infections are asymptomatic and spontaneously resolve, but they can cause oncogenic changes and lead to cervical cancer. HPV subtype 16 produces something called E6, which impairs a tumor suppressor gene known as p53. HPV subtype 18 produces E7, which impairs a different tumor suppressor gene known as retinoblastoma. These tumor suppressor genes are essential in regulation of transcription and removing mutations. The commonest histological subtype is squamous cell carcinoma, accounting for 80% of cases. Of the remainder, 10% of cancers are adenocarcinomas, and there are also rarer subtypes, including small cell cancer and lymphoma. Cervical adenocarcinomas are more often diagnosed at an advanced stage of disease. The commonest symptoms are postcoital bleeding, intermenstrual bleeding, or postmenopausal bleeding. Patients can also experience malodorous or blood-stained discharge, pelvic pain, or dyspareunia, which is pain during sexual intercourse. Many cases are also detected at an early stage when the patient is asymptomatic through the cervical cancer screening program. Other differential diagnoses to consider in patients presenting with these symptoms include cervicitis, which is irritation or infection of the cervix, dysfunctional uterine bleeding, cervical ectropion, which is when cells that line inside of the cervix grow on the outside, pelvic inflammatory disease, endometrial cancer, and endometrial hyperplasia. Premenopausal women who present with abnormal vaginal bleeding should be tested for chlamydia. Postmenopausal women should be urgently referred to gynecology to rule out endometrial cancer. Cervical screening has been an important part of preventing cervical cancer, as it means that it is often in the pre-malignant stage at diagnosis where it is easier to treat. The UK cervical screening programme is offered to every 3 years to women aged 25 to 49, and every 5 years for women aged 50 to 60 years old. During screening, a speculum is inserted and the brush is rotated 360 degrees in the cervix to obtain cells. First, the sample is tested for human papillomavirus. If this is positive, the sample may be sent for further cytology analysis, which is where cells from the smear are examined for evidence of dyskaryosis. This is an abnormal appearance of epithelial cells. Features of dyskaryosis include an enlarged nuclear to cytoplasmic ratio, hyperchromatic nuclei, which means that it appears darker on staining, and an irregular nuclear membrane contour. Koilocytes may be seen, which are dyskaryotic squamous cell epithelium, and these have been infected with human papillomavirus. In contrast, normal cervical squamous epithelium has more cytoplasm and smaller nuclei. If cytology shows abnormal cells, then the patient will be sent for colposcopy, where a sample of tissue is removed from the body through biopsy. Cervical intraepithelial neoplasia, known as CIN, is a precancerous condition where abnormal cells grow on the surface of the cervix and it can be identified through colposcopy. Investigations for suspected cervical cancer include typical blood tests such as a full blood count, liver function tests, and urea and electrolytes. Colposcopy is diagnostic, and a cone biopsy is taken during this procedure to be analysed further. Imaging can be done to assess the disease burden and spread, such as CT, MRI, and PET. The FIGO staging system is commonly used to stage cervical cancer based on the involvement of surrounding lymph nodes and tissues and the depth of invasion. Management depends on the stage of disease and the patient's wishes. The aim is to achieve a cure if possible or to prolong the disease-free period. In advanced disease, palliative care input is important. For stage 1A1 disease, known as micro-invasive disease, a LETS procedure is done. This is known as large loop excision of the transformation zone. Or a knife cone biopsy can be used to remove the abnormal cells. Because the risk of lymph node metastasis is low, a lymphadenectomy is rarely warranted. A simple hysterectomy may be considered, especially if the patient is not keen to preserve fertility. For stage 1A2 to 2A early stage disease, there is a risk of spread to pelvic and para-aortic lymph nodes. A modified radical hysterectomy with lymphadenectomy may be done. In premenopausal women, ovarian conservation and fertility-sparing treatments may be considered. If the disease is more than 4 centimeters, then chemoradiation may also be given in addition, and this is a combination of chemotherapy and radiotherapy. For stage 2B to 4A, known as locally advanced disease, the treatment of choice is commonly chemoradiation. For stage 4B, known as metastatic disease, a combination of chemotherapy, single agent therapy, and palliative radiotherapy may be used. As human papillomavirus has been identified as a strong risk factor for cervical cancer, the Gardasil vaccine is now given to all boys and girls aged 12 to 13, as this protects from HPV 6, 11, 16, and 18. It is also offered to all homosexual men aged under 45 years, as the vaccine can protect against anal, throat, and penile cancers. It is thought that the incidence of cervical cancer will decrease in the coming decades due to HPV vaccination. In summary, human papillomavirus is the biggest risk factor for cervical cancer. Cervical cancer is now often detected at a pre-malignant stage due to cervical screening. The HPV vaccine Gardasil is thought to reduce the future incidence of cervical cancer, and treatment depends on the stage of disease and can include hysterectomy and chemoradiation. Thank you for watching.